Assalamualaikum warahmatullahi wabarakatuh and very good morning. A warm welcome to all participants from Malaysia, the SEAMEO network and affiliated countries to our first IMR SEAMEO Webinar series in 2026. The theme for today is School-Based Approach to Childhood Obesity Intervention, Protocol and Results of MyBFF at School. Our both presenters today and me, Dr. Fazliana Mansor, as the moderator for today's session, are from the Endocrine and Metabolic Unit, Nutrition, Metabolism and Cardiovascular Research Centre, NMCRC, Institute for Medical Research, Malaysia. Our research centre carries out non-communicable diseases, research, consultation and training, where the focus areas are on nutrition, cardiovascular, rare diseases, and metabolism-related disease. Okay. Our unit, the Endocrine and Metabolic Unit, we focus on this area, endocrine-related diseases, which covers the PCOS, diabetes nephropathy, and also diabetes and its complications, where we use various techniques for various research. And our main focus is on obesity and metabolic syndrome, where we do preclinical and clinical studies, where we carry out intervention and also some clinical studies. Okay. The theme today covers the work that we have been carried out on obesity research. So ladies and gentlemen, the webinar series was initiated with the aim to share the knowledge, discuss topics on biomedical research and present research outcomes. Before we begin the presentations today with our two distinguished speakers, allow me to announce a few housekeeping messages from the Secretariat. The first one, we will not be taking questions during the presentation, but participants may post their questions using the link shared in the YouTube channel. Second, the question and answer session will be conducted after both presentations have ended. Then an attendance link is also provided in the YouTube channel for those who would like to receive an e-certificate of attendance. And lastly, please subscribe to our National Institute Health Malaysia YouTube channel and click for notification whenever there is a new post. Ladies and gentlemen, in a recent systematic review and meta-analysis, a study provides pooled data for Malaysian children where the prevalence of childhood overweight, obesity and excess weight in Malaysia almost doubled over 26 years. Therefore, today's theme is very relevant with our concern on the health of future generation. So for today, we have two speakers from our unit whom both have authored and co-authored numerous publications in the international peer-reviewed journals and have actively presented their work at both national and international scientific conference. Our first speaker is Dr. Zati Iwani binti Ahmad Kamil, graduated from the Manchester University, UK, where now she holds a doctoral degree in biomedical science from University of Malaya, Malaysia. Dr. Zati Iwani's research focuses on childhood and adolescent obesity, insulin resistance, and cardiovascular risk factors, with expertise in biochemical and hormonal profiling, as well as advanced statistical modeling, including structural equation modeling. She is part of a pioneering research team in Malaysia investigating the use of the triglyceride to HDL cholesterol ratio as a marker of insulin resistance among children and adolescents. So today, Dr. Zati Iwani will be sharing her research experience in a presentation titled MyBFF at School, Setting the Stage, Protocol and Baseline Results of Childhood Obesity Intervention. So Dr. Zati, the screen is yours.
Assalamualaikum. Thank you, Dr. Fazliana, for the kind introduction. Assalamualaikum and a very good morning to all. I am Dr. Zati Iwani binti Ahmad Kamil, a research officer from the Endocrine and Metabolic Unit, Institute for Medical Research. Okay, today I will begin our webinar session with a presentation titled MyBFF at School, Setting the Stage, Protocol and Baseline Results of a Childhood Obesity Intervention Study, in which Dr. Fazliana, Puan Mona and myself were part of the research team. Childhood obesity is a growing public health issue in Malaysia, especially among school-age children. Excess body fat at this stage is strongly associated with early metabolic problems such as insulin resistance, dyslipidemia, and increased cardiometabolic risk, often developing before diabetes become apparent. These risks frequently persist into adulthood, making identification and intervention critical. Schools offers an ideal setting for interventions, as children's lifestyle behaviors are still highly modifiable. In response to this, My Body is Fit and Fabulous at School, or MyBFF at School, was developed as a school-based program to address overweight and obesity among Malaysian school children. MyBFF at School is a collaborative effort between Ministry of Health Malaysia, Ministry of Education Malaysia, Nutrition Departments of Ministry of Health Malaysia, University Malaya, Global Science and Innovation Advisory Council Malaysia, Malaysia Industry Government Group for High Technology, and also Institute Sukan Negara Malaysia. Here are the pictures of MyBFF at School team. On the left is our research assistant for the MyBFF at School program, and on the right hand side is our research team of MyBFF at School study. Before I move forward with the detailed protocol of MyBFF at School intervention, I would like to first introduce what is MyBFF at School component or package. MyBFF at School, in the nutshell, comprised of 3 key modules, that is the physical activity module, nutrition module, and also psychology module. For the physical activity module, MyBFF at School introduced the small-sided games, or SSG. SSG is a modified sports activities with simplified rules, fewer players, and smaller playing areas. For example, the school children can play football with 4 versus 4 instead of 11 versus 11 on a small pitch for 5 to 10 minutes. With fewer players and a smaller space, every children moves more, thinks more, and learn to work as a team. Additionally, the rules of the game can also be modified, such as no offside, adaptive scoring, and so on. In general, SSG was conducted 30 minutes per session in primary schools and 40 minutes per session in the secondary schools. The second component is the nutrition model. First, the nutrition team targeted the canteen operators and the related teachers like the guru penolong kanan. For the canteen operator, we aim to increase knowledge and skill on healthy food preparation. Following the standard module latihan catering sihat, covering principles of healthy eating, healthy meal preparation, food safety and hygiene, and also the effects of poor diet. Second, we also approach the school children. For the school children, the nutrition team follow the nutrition education module, which covers topics such as my body weight, where we introduce BMI and growth charts to increase understanding of healthy body weight and others. We also introduce Eat Well, Be Well, which teaches the children to choose healthy and nutritious diet for their growth. Additionally, the nutrition modules also teaches the children how to read and understand nutrition labels and choose food wisely, so that they can choose their diet accordingly. The nutrition module was conducted within 45 to 60 minutes per session, alternately with the psychology module every other week. Moving on to our third component, that is the psychology module or psychology component. Psychology component was developed to strengthen the psychological aspects of the children. This module was adapted from the Dr. Muda program. Psychology module focus on behavior changes and self-empowerment for stress management, and also to have confidence in reducing their body weight. The main theme of the module were motivation, positive thinking, assertiveness, social skills, self-esteem, and also stress management. These three components were the core of MyBFF at School. MyBFF at School is divided into two phases. The first phase is the pilot study and also the actual implementation. MyBFF at School pilot study was conducted in 2014. The principal investigator of the MyBFF at School was Dr. Wan Muhammad, our former head of Cardiovascular and Nutrient Research Center, Institute for Medical Research. MyBFF at School was piloted in Putrajaya. It involved students with obesity in the primary and secondary school. A total of 425 children participate in the study, with 237 primary school students aged 9 to 11 years old and also 188 secondary school children. MyBFF at School was conducted after school hours. Challenges and improvements were determined from this pilot study, which I will present in the next slide. Phase 2, or the actual program of MyBFF at School, was conducted in 2016, which was led by Professor Dr. Abdul Halim Mokhtar from University Malaya, following the retirement of Dr. Wan Nazaimun. From the pilot study conducted in 2014, we found that the school teachers were tied up with their own school responsibilities. Therefore, dedicated personnel trained specifically for the MyBFF School program were stationed at the upcoming participating schools. Additionally, we also found high attrition rate as MyBFF at School was conducted after school hours, and majority of the school children had other additional classes to attend after their school hours, including religious schools such as Kafah. Logistic issues were also another reason contributing to the high attrition rate in the pilot study. Following a series of meetings and discussion with the Ministry of Education Malaysia, approval was obtained to integrate MyBFF at School into the school timetable. From now on, all of the objectives, study design, methodology, and also baseline results will be referring to the MyBFF at School program, MyBFF at School program conducted in 2016. MyBFF at School was primarily aimed to evaluate the effectiveness of the MyBFF at School program on overweight and obese school children's BMI for age and also percentage body fat after 3 and 6 months of the intervention. Additionally, each module have their own secondary objectives. The first one is to study the effects of MyBFF at School program on the physical fitness outcome and enjoyment through physical activities. Second, to compare the knowledge, attitude, and practice on nutrition among primary and secondary school children between the intervention and control group. And the third one is to determine the impact of the MyBFF at School program on emotional and behavioral well-being among the primary and secondary school children. MyBFF at School is a cluster randomized control trial. We conducted proportionate random sampling for the selection of schools from Kuala Lumpur, Selangor, and also Negeri Sembilan. This is to ensure sufficient representation of multi-ethnic populations in the study sample. The selected schools were then randomly allocated to either intervention or control arm of the study. We included primary school children aged 9 to 11 years old and also secondary school children aged 13, 14 and 16 years old with BMI for age more than 1 SD. We excluded children with following conditions such as physical or medical conditions that prevented their participation in moderate to vigorous physical activities, and also those having existing comorbidities and on certain medication treatments such as steroid and anti-epileptic. For primary school children, at baseline, we screened almost 12,000 children, and among them, about 3,500 of the children were eligible to participate. After our explanation on the detail of the MyBFF School program and the commitment required from them, 1,397 children consented to participate. These children were then divided into intervention and control based on their schools. The intervention schools will follow the MyBFF at School program, whereas the control school will follow the National Standard Physical Education and Curricular Activity. For secondary schools, at baseline we screen about 11,000 children, and among them about 2,900 children were eligible to participate. And then after examination, also on the detail of MyBFF School program and the commitment required from them, a total of 1,041 children consented to participate in MyBFF School program. Similar to the primary schools, these children were then divided into either intervention and control school based on their schools. Now we are moving on to the delivery or implementation of the MyBFF at School package. MyBFF at School was conducted over 6 months, 6 month period between February and August 2016. As I mentioned earlier, the program was integrated into school's hours, replacing the usual physical education and co-curricular activity periods. Instead of following the national standard curriculum, participants of the intervention school underwent MyBFF at School program. To make sure the program runs smoothly, full-time trained personnel were stationed at the participating schools. They were supported and guided by dedicated central and field supervisors throughout the program. Physical activity sessions using small-sided games were conducted twice weekly, totaling 60 minutes per week in primary schools and 80 minutes per week in the secondary schools. Nutrition and psychology module were delivered alternately every other week during the co-curricular hours, with a weekly duration of 45 minutes in primary schools and 60 minutes in the secondary school. To ensure, in addition, to strengthen the program and better reflect the actual implementation, our personnel were graduate with a degree in nutrition, allied health science and sports sciences. We conducted 2 structured programs conducted by the research team who are sport physician, sport coach, nutritionists and also psychology experts. After that, a certificate of competency were issued to these personnel. During the implementation of MyBFF at School, 2 further refresher courses during the intervention was conducted to consolidate skills. For the MyBFF at School, we conducted assessments at 3 time points. First, at the baseline before the start of the intervention, at 3 months, and also at the end of the intervention at 6 months. The following tables show the parameters and outcomes that were measured at each time point. Socio-demographic data, anthropometric measurements, clinical assessment, body composition, and also fitness tests, that is the modified Harvard test, were measured at all 3 time points. However, self-administered questionnaires for the nutrition and psychology and also blood taking for cardiometabolic assessments were only measured at baseline and month 6. In this presentation, I will be sharing the overall baseline results of the MyBFF at School program to give us a general picture of the characteristics of the school children involved. The detailed outcomes and intervention-related changes will be presented later by Puan Ruziana Mona. So please bear with me for just a little while longer. Yeah? Okay. For primary schools, at baseline, the mean age was 9.9 years old, with 53.8% boys and 46.2% girls. Ethnic distribution was almost comparable to Malaysian ethnic group in 2016, with 58.8% Malay, followed by 15.3% Chinese, 6.9% Indian, and 3.2% of other ethnicity. Majority of the schools were located in the urban area. For the obesity status, we found that about 40% of the children were either overweight or obese, and worryingly, about 17.6% of them were children with morbid obesity. Additionally, 66.9% of the children were found to have abdominal obesity. This is concerning because excess abdominal fat is strongly associated with higher risk of metabolic complications, including insulin resistance and future cardiometabolic diseases even at a young age. Moving on to the socio-demographic characteristic for secondary school children. At baseline, the mean age was 14.2 years old. In secondary schools, 41.3% of the school children were boys and 58.7% were girls. 67.2% were Malay, followed by 13.1% Indian, 5.6% Chinese, and 3.4% of other ethnicity. Similar to the primary schools, majority of the schools were located in the urban area. For the obesity status, the trend was also similar to primary schools, where we found that more than 40% of the children were either overweight or obese, and 11.4% of them were children with morbid obesity. Again, more than half of the children were found to have abdominal obesity. Okay, let's have a look at the anthropometric measurements of the school children. Similar to the socio-demographic result, both primary and secondary school children have similar characteristics. Gender-wise, boys have higher BMI score and larger waist circumference as compared to girls. However, girls have higher percentage body fat. As for skeletal muscle mass, only secondary schools boys have higher skeletal muscle mass compared to girls. No skeletal muscle mass difference was observed in the primary school. As we can see from our baseline screening and the baseline outcome, without early and structured intervention, many children with obesity probably grow into adults with long-term health problems such as diabetes and heart disease. That's why early action is so important. Schools are the perfect place to start. Children spend most of their day at school, and programs like MyBFF at school fit naturally into their daily routines, making healthy habits easier to learn and practice. MyBFF at school uses a multi-component approach combining fun physical activities, nutrition education, and behavioral support, as obesity is influenced by many other factors, not just diet alone. Behavior change is our core focus. By helping children build healthier habits early, we increase the chances that these behaviors will carry on into adolescence and adulthood. Most importantly, MyBFF at school tracks measurable outcomes, ensuring that the program is effective and continues to improve. Early intervention can change a child's health trajectory, and that's the real value of addressing childhood obesity early. Okay, before I end my presentations, I have listed MyBFF at school scientific publications as a reference. I would also like to take this opportunity to thank everyone who was involved in the MyBFF at school program, both directly and indirectly, especially to the teachers and school children from the participating schools. Here are some pictures from our fieldwork. This is during the assessment and during the nutrition module implementation. Okay. That's it. Thank you. We'll now pass the mic to Dr. Fazliana.
Okay. Thank you, Dr. Zati Iwani, for giving us the insights of our local children obesity intervention. I'm sure the viewers are eager to know about the more results and more sharing from this research. However, I would like to remind here, if you have any questions, I'm sure you have many questions. There are many things that you have in mind. Okay, so if you have questions about the presentation, kindly submit your questions using the link provided in the YouTube channel. So we move to the next slide. Okay, sorry. Okay, to the next speaker. Next, I would like to introduce our second speaker for today, Puan Ruziana Mona Wan Muhammad Zain. Puan Ruziana Mona holds a Bachelor of Science with Honours in Biotechnology from Cardiff University, United Kingdom. Her research interests include obesity and metabolic syndrome, with a particular emphasis on intervention-based research. Now, she also embarked her research journey on diabetes biomarkers studies using metabolomics and lipidomic technique. So it is our privilege to have Puan Ruziana Mona with us to share her research findings. Her presentation title is Beyond Weight Loss, Body Composition and Metabolic Benefits of a School-Based Lifestyle Intervention. Over to you, Puan Ruziana Mona. The screen is yours.
Thank you to our moderator, Dr. Fazliana, for the kind introduction. Good morning, everyone, and thank you for joining us today. My name is Ruziana Mona Wan Muhammad Zain, and today I will be sharing our work titled Beyond Weight Loss, Body Composition and Metabolic Benefits of a School-Based Lifestyle Intervention. In this talk, I would also like to show you why looking at only weight or BMI or body mass index does not always tell the full story, especially when we are talking about children with overweight and obesity, and how a school-based lifestyle intervention program can lead to a meaningful health improvement beyond weight loss. Earlier, you just heard from my colleague, Dr. Iwani, about the study methodology and also our baseline characteristic of our school-based intervention called My Body is Fit and Fabulous at School, also known as MyBFF at School. My role today is to focus on what changed after 6 months of this intervention. Specifically, I will be talking about outcomes beyond weight loss among primary school children aged 9 to 11 years old. We will look at 3 main areas. First, we will look at the changes in body composition, meaning fat and muscle in our body. Second, we will look at the changes of cardiometabolic risk factors, which indicate our heart and metabolic health. And lastly, we will look at cardiorespiratory fitness changes after the intervention, which reflects how well our lungs and heart work during physical activity. In addition, I will also briefly touch on how children with different metabolic phenotype responded differently to the intervention. I will later introduce to you the concept of metabolically healthy obesity versus metabolically unhealthy obesity. First, let's look at the changes of body composition. In total, for the primary school children, we had nearly 1,400 participants from 23 schools across Klang Valley. 647 children were assigned to the intervention group where they followed the MyBFF at School program, and 750 children were assigned to the control group where they continued with their usual physical education classes. We compared changes before and after 6 months, and we analyzed the data according to the intention to treat principle. This means that we will include all the children who were enrolled regardless if they finish the 6 months duration or not. We measure body composition using bioelectrical impedance analyzer, as you can see in the picture. It safely measures muscle, fat and body water by sending a very small electrical signal through the body, which travel differently through each tissue type. The children were required to stand barefoot on the machine and hold the hand electrolyte for about 1 to 3 minutes. The machine will then give us the segmental analysis of the body. Now, to understand changes in body composition, we did not just look at the change in body weight. We also measured BMI Z-score, body mass index adjusted for age and gender, waist circumference, skeletal muscle mass, and also percentage of body fat. These measurements help us understand how the body is changing after intervention, not just how much it weighs on the scale. For accuracy, the measurements were taken at early morning after an overnight fasting and in light clothing before the children have their breakfast. First, let's look at the BMI. After 6 months of the intervention, we found no significant change in BMI Z-score in either group. This, at first glance, this might sound disappointing because when we are dealing with the weight loss program, we often want to see the changes on the BMI or changes in weight. However, BMI alone does not always reflect changes in body fat or muscle, especially in growing children. This is why relying on BMI alone can sometimes miss important health improvement. Next, let's look at the changes in the waist circumference. We observe a significant but small increase in waist circumference in both groups. And importantly, there was no difference between the intervention and control group when we compare between the group. This increase is expected in growing children as the child increase in stature, which means that they grow taller and develop. Their waist measurement naturally increases, and this does not necessarily indicate worsening health or increased fat around the belly. Next, we look at the changes of the skeletal muscle mass. From here, as you can see, we saw a very encouraging result. Muscle mass significantly improved in both groups after 6 months of the intervention. However, we observed greater improvement in the intervention group. What does this mean? This suggests that the MyBFF at School program helped give added bonus in helping children develop more lean, healthy muscle, healthy tissue, which is important for strength, metabolism, and overall health. And finally, we also look at the percentage of body fat. Both groups also showed a significant reduction in percentage of body fat, but once again, the reduction was seen significantly greater among the intervention group. What does this finding mean? When we consider the result together, increase in muscle mass and reduced body fat, we can see clearly improvement in the body composition, even though body weight itself did not change much. So as a key takeaway, to summarize the body composition findings, even though BMI did not change after the intervention, our school-based intervention successfully increased muscle mass and reduced body fat. This finding highlights an important message. Health improvement in children should not be judged alone by weight. Measures of body composition provide valuable insight into the real benefits of lifestyle intervention in children with overweight and obesity. Next, let's move on to the cardiometabolic risk factor. What does cardiometabolic risk factor means? Why it is important to measure cardiometabolic risk factor? Cardiometabolic risk factor are health indicators that tell us about a person's risk of developing heart disease or type 2 diabetes over time. Looking at this factor together help us to understand more and also to help identify problems early. For this purpose, blood taking is optional. Only those that consented for blood included in this analysis. Surprisingly, about 60% of our total participants consented for blood taking, which means about roughly 7 out of 10 participants consented take part in the blood taking. For cardiometabolic risk factor, we look at several indicators of metabolic health. This included blood pressure, insulin resistance, which is linked to how good our body controls blood sugar, and also blood lipids. All blood samples were taken early morning after an overnight fasting, following a standard clinical procedure. First, let's look at the blood pressure. Over the 6-month period, we observed a small but significant increase in systolic blood pressure in both intervention and control group, while diastolic blood pressure remained stable. This increase in blood pressure is expected in growing children. As children grow taller, their heart and blood vessels also develop, which naturally leads to slightly higher systolic blood pressure. Therefore, this finding reflects a normal growth-related cardiovascular changes rather than a negative effect of our intervention. Next, we look at how well body responds to insulin, a key factor preventing conditions like type 2 diabetes. We use a well-established index, homeostasis model assessment of insulin resistance, also known as HOMA-IR index. HOMA-IR index estimate insulin resistance based on fasting blood sugar and also insulin levels. After 6 months of the intervention, we observe a significant reduction in home IR, which means a significant improvement in insulin sensitivity in the intervention group. Although the control group also showed a reduction trend. However, this reduction is small and not significant. When we compare the two groups, children in the MyBFF at school had a greater improvement in the insulin sensitivity than those in the control group. This is an important finding because insulin resistance can develop early in life and even in children and increase the risk of future metabolic disease if left unchecked. Lastly, we examine the changes of blood lipids after the intervention. Both groups showed a significant increase in HDL cholesterol, also referred to as good cholesterol. However, again, when we compare the two groups, the increment is significantly greater in the intervention group when compared to the control group. This suggesting an added benefit of our MyBFF at School program to the overall health. We did not observe any changes in triglycerides after the intervention in either group. We also look at the ratio between triglycerides to HDL cholesterol, which is another indicator of that links to the metabolic health. Encouragingly, both groups improved their TG-HDL ratio by the end of the intervention. So as a summary, MyBFF at School program improved metabolic health in primary school children by improving the body's response to insulin and also increasing levels of HDL cholesterol, which is good cholesterol. This benefit were observed even without major changes in weight, and this is important. This is reinforced that the idea that healthy lifestyle intervention can improve child's internal health, not just their appearance on the scale. Next, we look at the changes of the cardiorespiratory fitness after 6 months of intervention, which reflect how well heart and lungs work during physical activity. To assess this, we use a simple, well-established method called as a modified Harvard step test. In this test, as you can see in the picture here, child were asked to step up and down a small platform at a steady pace for 5 minutes, as you can see in the picture. While they are doing the test, we monitored their heart rate and also oxygen level. So upon completion of the test, they were immediately asked to sit down on the platform, and the recovery heart rate at 0, 1 and 2 minutes were recorded to calculate the physical fitness score. Here, for the interesting part, I will show you the video taken from the YouTube just to see how it is done.
Today we're going to be performing the Harvard step test. This is an aerobic test. The equipment required is a stepping block of 20 inches, a stopwatch and a metronome.
The athlete steps up and down on the platform at a rate of 30 steps per minute, which is equivalent to a step every 2 seconds for 5 minutes or until exhaustion. Exhaustion is defined as when the athlete cannot maintain a stepping rate for 15 seconds.
Ah, yes. Well, looky here, what do we have? Another pretty thing ready for me to grab. But little does she know that I'm a wolf in sheep's clothing, 'cause at the end of the night, it is her I'll be holding. I love you so, hey, that's what you'll say. You'll tell me, baby, please don't go away. But when I play, I never stay. So every girl that I meet, yeah, this is what I say. Run away, baby. The fire from my spell on you. You better get away, darling. 'Cause everything you heard is true. Your poor little heart will end up alone. 'Cause Lord knows I'm a rolling stone. So you better run away, baby. Ah, yeah.
As you can see, our participants' results at the end of the test shows heart rate decreasing from 86 to 66 beats per the 30 seconds we were recording over the 3-minute period of recovery. The way to work out his fitness index is by following this equation: 100 times the test duration in seconds, which was the full 5 minutes, divided by 2 times the sum of the heartbeats in the recovery period. Our participant scored 64.9, which we would round up to 65. As you can see on our normative data chart, this would place him in the below average category. We would keep these results on record for next time he attempts the test. This concludes our test for today. I hope it has been helpful for you.
Mana nak next? Okay, sorry for the technical issues just now. It's echo a bit. Okay. So how is it? It's fairly simple, right? You can just do it at home to test, to check your own physical fitness score if it's moderate or weak. So moving on, after 6 months of intervention, we found that the physical score improved significantly in both groups. Although the difference between group was not significant, but the intervention group showed a greater trend toward improvement. There are a few important reasons why we might see similar improvement in both groups. First, we did not record detailed information on the physical education activities conducted in the control school, which may also contribute to the improved fitness. Secondly, we do not measure the intensity of physical activity, which is an important factor when evaluating fitness changes. Despite this limitation, the overall improvement in fitness is an encouraging finding, as better cardiorespiratory fitness is strongly linked to the heart health. This finding also highlights that the importance of structured and consistent physical activity in school in improving physical fitness among children with obesity and overweight. Finally, we look at whether children responded differently to the intervention based on their metabolic health. Before that, let me briefly introduce an important concept. Not all children with obesity have the same level of health risk. For some children, they have obesity, but their blood pressure is normal, blood sugar is normal, and also lipid levels are normal. These children are often referred as having metabolically healthy obesity. On the other hand, some children with obesity already show early signs of metabolic problems, such as abnormal blood lipids, blood sugar, or blood pressure. These children are called having metabolically unhealthy obesity. Currently, there are no universally accepted definition for the metabolic health. Therefore, for the purpose of this study, we adapted the 2018 consensus-based criteria to classify our participants into either metabolically healthy or metabolically unhealthy obesity. To explore this further, we conducted analysis using data from our earlier pilot study conducted in Putrajaya in 2014. A total of 102 participants completed the MyBFF at school intervention. This is only from the intervention arm. So they were classified as either having metabolically healthy obesity or metabolically unhealthy obesity at baseline. After the intervention, we observed that children with metabolically unhealthy obesity, here I use short form as MUO, showed significant improvement in systolic blood pressure, diastolic blood pressure, and also HDL cholesterol, which is, again, good cholesterol. Meanwhile, children with metabolically healthy obesity showed a significant reduction in uric acid levels, which is another marker linked to cardiometabolic risk. These findings suggest that lifestyle intervention can benefit both children with metabolically healthy and metabolically unhealthy obesity, but children with poorer metabolic health may benefit better. As with all research, there are some limitations that should be acknowledged. First, our intervention period was relatively short, lasting only for 6 months. Current recommendations suggest that longer intervention, often at least 12 months or more, may lead to a more sustained benefit. Second, our program focused mainly on the school environment. We did not directly measure lifestyle behaviors outside school, such as their diet choices and also physical activity at home. Since parent and home environment also play an important role in shaping children's habit, extending lifestyle changes to the home setting is critical to maximize long-term impact. As a conclusion, MyBFF at School multi-component intervention lead to meaningful improvement in body composition, metabolic health, and also physical fitness among primary school children with overweight and obesity. Importantly, these benefits were observed beyond weight loss, highlighting the value of comprehensive lifestyle program in improving children's overall health. Before I end, I would like to express my sincere appreciation to the entire study team, which dedication made all of this possible. I would especially like to thank our principal investigator, Prof. Dr. Abdul Halim Mokhtar, and also, as well as our components head, Prof. Dr. Muhammad Yazid, Dr. Fuzi Ahmad Zain, Puan Rusida Slamat, and also Prof. Dr. Zahari Ishaq, and also the rest of the research team, Dr. Janet, Dr. Corey, Dr. Chong, just to name a few, for their continued guidance and commitment throughout this project. With that, thank you very much for your attention. I will now pass the session back to our moderator, Dr. Fazliana.
Okay, thank you, Puan Ruziana Mona, for sharing your research findings and introduce us to the new term of metabolic phenotype. I'm sure most of us, this is our first time heard the term metabolically healthy obese and metabolically unhealthy obese. Actually, I want to remind the viewers to send questions, but we are already flooded by many questions. So I think we should go straight to the questions posted by our viewers. Okay, I think I'll start. Okay. Okay, I read in Bahasa first because I think this is important. From Yati IL KKM Sabah, bagaimana nak kontrol anak makan terlampau banyak? Sounds like me, okay. Macam mana nak ajar anak supaya dia faham keburukan obesity? Okay, the first one, how to control if your child or children eat too much. How to teach children or your kids to understand about obesity. Okay, just to clarify, but we are going to try to answer this as well. I'm also in the research team. So in IMR, Institute for Medical Research, we focus mainly on the biomedical research. As mentioned before or shared before, this is a study which involve many departments, many departments. So the expert in this area is actually bahagian pemakanan or nutrition division in KKM. But as general guidance, I think the Ministry of Health has guidelines on how to eat healthily. I think there is a guideline officially in the Ministry website. You can check there. But I think generally we eat moderately. But for kids, I think there is, of course, we have to advise them psychologically, or us as parents, we show examples. If you have any question or if you want more detail, please drop us your email so we can get the answer from the expert in nutrition or dietetics. Okay, we have many. Okay, this one, I think we don't cover this, but we try to answer as well. Okay. From Logeswari Krishnan IPTK, how did you assess behavioral changes among the primary school children? What tools or methods did you use to measure whether the behavior had actually changed over time? Yeah, psychology is one of the component. May I ask our yeah.
Okay, thank you for the questions. But as Dr. Fazliana said earlier, every component have their own expertise. And for this psychology, we have a team from by Professor Dr. Zahari Ishaq. He's the lead he's the lead researchers for this component. I don't think I can.
Okay,
yeah.
it's okay, Dr. Wani.
But I think we can refer to our publication. I'll share the link for the publication for this behavioral change.
Yeah, since this is also from the NIH, I think we can contact this person.
I'll email you.
We have also a booklet, or we actually have a book on MyBFF protocol. Okay, we go to quite similar question. Even not okay, this is interesting, but I think okay, bagaimana nak beri semangat untuk anak-anak menghadapi kawan-kawan di sekolah? Okay, how to give motivation for kids to go to school? But I think Puan Yushi from Hospital Kampa, I think what she meant was maybe the children have obesity issue and so on. Yeah, I think this is more behavioral aspect that we need to study, the stigma and also the understanding of other friends in school. This is not our expert area. How do you categorize children into morbid obesity? Which chart are you using, Doctor? I think this question go to Dr. Wani because it's protocol.
Okay,
from Nazatul, Pejabat Kesihatan Daerah Bentong Pahang.
Thank you, Puan Nazatul. For the obesity category, for MyBFF at school, we use BMI Z score from the WHO growth charts. But I think, Puan, there is a new category, right, for the obesity status in children?
For the newest guideline showed that for morbidly obese, there's we have to use percentile. Those more than, I can't really remember. I need to check again, Dr. Wani. So it's basically we need to see the median of our population, and those that higher 80%. I think it's 80% more higher than that. But I really have to check. If you drop us email, I will just share with you the newest guideline.
Okay, this is relevant. Any of you? From Mastura Hospital, from Puan Mastura Hospital Orang Asli Gombak. Very interesting yet compelling evidence, diverse sample. Congrats to the team. Thank you so much. It's a very strong teamwork. Since the intervention is 6 months period, is there any plan to do follow-up study to assess sustainability? Okay, to start with, I think our speakers can also add. This is our evidence. So what is going to be done in future is more of course, we need a budget to do this, but at the same time, we have to do follow-up if the same individuals. It's going to be a new study which have to be we really have to think through about it.
Yes.
Just to add on, even though we did not follow up these children after the intervention, but we already identify who at risk. So we, on top of that, we already referred them to the nearest clinic kesihatan. But still, it's really up to the parents to bring the children to get check-up.
Okay, maybe this one. If you don't satisfied with our answer and we are not the expert in that particular area, please send us email. We will direct you to the right expert. Okay, what changes would the MyBFF at school team make if program were to be repeated? Any?
Okay. For this one, I think from our observations, I think in MyBFF at school, we are missing one of the other core component, that is the parents' involvement. But as you can see, every intervention study have a challenge. So this is something that we might want to explore if we include parents' involvement in the intervention study. I think that is one of the new addition that we want to introduce.
Okay. Okay, I think this one is suitable for Puan Mona. Can a child switch from metabolically unhealthy to metabolically healthy?
Yes, this is interesting actually, because the metabolic phenotype has been reported to be transient, which means you can cross from healthy to unhealthy. So I want to show it earlier, but because we have time limit, based on our previous study, we have found that 50% of our participants cross from the metabolically healthy to metabolically unhealthy, whereas 1 in 4 participants cross from metabolically unhealthy to metabolically healthy. So if you can see here, it's really easy for metabolically healthy to cross to unhealthy. So it's very important to really watch our health.
Right. I think probably the last question, because we are running out of time. Answered already. Okay. Is MyBFF at school being officially a policy that will be implemented in school? Okay, very important question, and I think it's very important to share with all of you. As mentioned, so we do our research, and this is the evidence. It has been presented to our stakeholders. Not yet, but I think it should be discussed in depth, and should be taken part not just by one ministry. It should be done or carried out, work together with different ministry under our government. I think that's all questions that I can take for today. Yeah. So now. Anyway, thank you so much for your questions. We have a few more actually, but we don't have time for this morning. Please drop us an email and we will direct you to the right expert to answer. How time flies. Now we have come to an end of the webinar session. I would like to thank all participants for their support and to make this session successful. Don't forget to subscribe to our National Institute of Health Malaysia YouTube channel. And before I forget, I would like to announce that we will have the next session of the IMR SEAMEO Webinar series on the 27th of February 2026. So don't forget to mark your calendar. The theme for the next webinar is Why Drug Candidates Fail in Clinical Trials, the critical role of comprehensive preclinical. So we hope you can join us at the next session at the end of February. Until then, many thanks from all of us at IMR. Take care and stay healthy.
you.